has contributed extensively to diabetic education and research, and today he will be speaking on CGM in 2026, inflammation, CVD, nexus, and chasing the billions LDLc. Please welcome Dr. Suhas Erande, sir.
Good morning, gentlemen. Thank you very much, organizers, for involving me in this excellent conference in Varanasi, and that too in BHU. Let me clarify that it is just a sort of a misunderstanding that three topics which I had wished to speak on, the organizers were to select one, but they have included all the three topics, but I am speaking only on CGM in 2026. Thank you. So gentlemen, this is a known technology which we use in diabetes, and nowadays we use it even beyond diabetes also, which I will briefly touch upon. So while knowledge is power, knowledge alone cannot change the behavior for most of the people. So CGM is a tool, but so glucose monitoring is a backbone of managing diabetes, all of us appreciate. And it started with urine glucose monitoring, then went on to blood glucose monitoring. We started using glucometers around 4.5 decades back. And now we do what is called continuous glucose monitoring. Why is that difference significant? The traditional blood glucose monitoring can be compared to what is being a snapshot by a camera, but a continuous glucose monitoring is like a video shooting. So what happens all the time will be picked, and you can very clearly see that rather than the dots which tell the glucose story, the whole story is caught by continuous glucose monitoring. So if somebody is having a low or high sugar in between the 2 hours of fasting and postprandial, the interval, still that will be caught by CGM. And some CGMs do monitoring or record every 5 minutes, every 10 minutes, every 15 minutes, etc. It's very important that we adopt to this technology for better glucose monitoring. So this is the typical illustration which is given. On the left hand side we can see that there are different kinds of glucose monitorings. The HbA1c may not really tell us the full story. That's the essence of this slide. HbA1c is equal for both the gentlemen on the left hand side and the right hand side. However, the right hand side person shows lots of fluctuations or glycemic variability, which is both hyper as well as hypoglycemia, but the average is 7. So we want not only the average, but we also want the details because they are important for us and for the patient. So this is in brief the most popular or most, let's say, trendy freestyle Libre system which is being used. There are quite a few others also available, and essentially this is the sensor. The left hand side is the applicator, and the sensor looks like a 2 rupee coin. It's only 4 grams in weight. It is water resistant, and it can be applied to usually the subcutaneous. The sensor actually works in a subcutaneous space, so the stylus actually is submerged in the subcutaneous tissue or interstitial blood glucose, and this is the reader which gives you the glucose graphs depending on the respective sensor. So maybe every 5 minutes, maybe every 15 minutes, that way. The patient, if not, your team needs to really handhold the patient when they do. The patient sends you these kind of things, and you can see that at one snap there is a 8 hours of the past 8 hours of the graph of interstitial glucose which is plotted. The sugar which is of that point of time, that will be, this is in millimoles, so you multiply it by 18, so it is around 110 milligram per deciliter, which also you can see the arrow can be either horizontal, it can be perpendicularly down or up, or diagonally up or down, and that trend tells you whether the sugar is stable, whether the sugar is gradually moving up or down by around 2 milligram percent every minute. Up is usually 3 or more, or down is usually 3 or more. So that way you can decide on the decisions of the respective exercise, diet, or maybe insulin dose mostly in these kinds of situations. So This is something which is a technology of the thing. Nowadays, we also have not only interstitial glucose, but we also have a continuous ketone monitoring, which is especially useful for type 1 management. There are a number of randomized controlled trials. There is a plethora of them, few of them in type 2 diabetes, few in type 1 diabetes. They essentially underline the importance of why and how the continuous glucose monitoring helps the patient. So this is replace study, which tells us that if you use it in type 2 diabetes, there is a certain amount of reduction in the hypoglycemia. Impact study is in type 1 diabetes that actually tells us that there is an improvement in the time in range, and time in range is a criteria which we will discuss immediately. Interstitial sugar between 70 to 180, and we expect the patient to pass time more than 70% in time in range. So if the time in range is more, actually the HbA1c also is reflected better, and time in range more than 70% is aligned to HbA1c of around 7%, and that also is related to reduction of complications. Richard Bergenstahl is a world authority in the field of technology in diabetes, and in fact he is the one who is very instrumental in designing the whole idea of ambulatory glucose profile and continuous glucose monitoring templates. So in the real world data, he has shown that type 2 diabetes, if they use CGM, then there is a reduction in the hospitalizations. So that actually is going to improve the quality of life for the patient. The health expenditures also will come down. This is even more, you can say, robust study called as Commissaire study. In fact, I tend to quote this very many times. So you can see that there are four types of different monitorings. So one is the red ones are using self-monitoring of blood glucose, and the patient is either on a multi-dose insulin regimen, MDI, or a continuous insulin, subcutaneous insulin infusion, which is insulin pump. The blue ones are using continuous glucose monitoring, RT, real-time CGM, and multi-dose insulin regimen again, or the triangular exercise, blue and triangle, is the continuous glucose monitoring and an insulin pump. And you can very clearly see, even if the patient is using a pump, SMBG and pump, still if the patient is using a multi-dose insulin and a RT-CGM, then his profiles are better. So it is not the insulin giving method, CSII pump or a multi-dose insulin which we traditionally use, but it is the monitoring which is going to be more important for glycemic outcomes. This is an example of type 1 diabetes, and it is a very prolonged study. You can see it's more than 3 years of study. CGM in primary care, these are again different examples. Those who use CGM, their HbA1c certainly comes down. You can clearly see here the mean time in range of 70 to 180. If that is to be attained, then it is a CGM which helps the patient better than the glucometer or SMBG, and then mean time in range more than about 250. That also can be certainly brought down by effective use of CGM. Benefits of using CGM, even if the patient is using a GLP-1 therapy. If you would have listened to the teaser, the music around the conference, that is certainly mentioning semaglutide or tirzepatide, which are very potent therapies for glycemic control and organ protection. However, on the top of that, if we use a CGM, then naturally you can see that GLP only is certainly successful, but if you use GLP and CGM, then there are better outcomes in these patients. So these are very accurate. This is just to show the meritocracy. This is something which is called as a mean average relative difference of the given sensor, how close the sensor reading is to the actual true glucose. This is the comparison that's called as parse grids, and you can see that the MAR is 10, less than 10 is something which is optimum, less than, this is 9.2, but there are new sensors which give you even less than 8 of MAR. So they are very, very accurate as far as the glucose control is concerned, especially glucose readings on the sensor in the low glucose range or hypoglycemic range is something which is more important, challenging more technologically. Sugars which change very fast, that also is another area where sensor meritocracy is very, very important. But these sensors certainly give that advantage. The patient has benefits. There is no finger prick which is required. He can see the readings as many times as is possible. He can maneuver the insulin management better, exercise management better. He can do the lifestyles in a more precise manner. You can handhold the patient better. I can always show lots of my patients sending their glucose graphs, the sensor graphs, and I keep on advising them on multi-dose insulin or maybe the pump adjustments. And very importantly, the patients certainly are free as far as the pricks are concerned. They have better quality of life. They can steer clear of hypoglycemias. The sensor, because they are going to work along with the smartphones, so the patient can actually be helped by either hypoglycemia sensor or hyperglycemia sensors, and they can act promptly on that. What are the existing guidelines? The 2026 ADA guidelines tell that CGM should be used for type 1 diabetic patients as long as possible, as allowed by the situation and finances. Most of the type 2 diabetic patients on insulin, whether it is only single dose of insulin, still they should be using more of CGM. For people with diabetes and asymptomatic hypoglycemia or problematic hypoglycemia, those who are struggling for control and having a lot of hypoglycemias, CGM certainly is recommended by the ADA. Also, pregnancy and diabetes, another indication for CGM. For newly diagnosed diabetes and wherever the consultant feels that CGM is going to help the management, yes, CGM should be used. With RT-CGM or intermittently scan CGM, varieties of CGM, available only on prescription till late, now they are available also on the counter. So they can order online. So there the situation comes where whether the use of CGM is to be actually rationalized or not, but that's a different discussion altogether. Whether non-diabetics should use CGM is a different kind of discussion. So that is something which is a challenge these days which we have to handle. Our own RSADA used to guide extensively on SMBG around 20 years ago. Now they also have given guidelines on CGM as far as the relatively newer areas are concerned. Mind you, any repeated monitoring, any investigation is bound to make actually overburden the patient. So SMBG also used to give a lot of stress. Quality of life, DIGM study was published. SMBG was associated with depression in the ESMON study. That was more than 20 years ago. But CGM also can overwhelm the patient. The alarms can make the patient fatigued. The local injection or the insertion of the sensor, that can give rise to some problems in some patients. So all these need to be handled by you. Essentially, I told you the sensor is inserted in the subcutaneous, so the Teflon goes inside the stylus. It is submerged in the interstitial tissue. And Freestyle Libre, that's the popular sensor, measures the glucose in the interstitial fluid. Glucose in the interstitial fluid has proven to be a reliable indicator of blood glucose as well. And the glucose diffusion between the capillary vessel and the intracellular fluid has a delay of approximately 5 to 10 minutes. This is the interstitial compartment. So we have to keep it in mind. If the patient continuously compares the sensor sugar and the capillary or the glucometer sugar, then he has to be actually reminded that when glucose levels are stable, the meter and the sensor readings could be same, but interstitial glucose reading tend to lag behind the SMBG. So if this is showing 200 right now, after around 5 to 10 minutes, the sensor will show 200. That's to be kept in mind. And blood glucose won't always match the sensor. That is to be taught to the patient. Then the arrows, I told you, they tell you which way the sugars are going, the trend of the sugar which is traveling. So depending on the direction of the arrow and the sugar at that point of time, you can always adjust your treatment accordingly. So these are the this is the summary of the benefits of CGM. Increases, if you improve the time in range, that's always going to improve the HbA1c and reduce the micro as well as macrovascular complications. Hypos are, you can say, better avoided by using CGM, so the quality of life improves. Number of hospital admissions, emergency room visits, they certainly come down. Work absenteeism is certainly going to come down with the use of CGM. Some examples I'm giving you. This is the way the CGM graph looks. Those of you who use it, they always know that 70 to 180 is the usual time in range for most of the patient. And above that is the yellow demarcation, that is time above range, 180 plus. Below 70 is usually depicted as pink or red, that is time below range. And time in range should be 70%, time above and time below should be as less as possible. Different types of patient, these are the world recommendations published 2019. So that's the way the typical CGM report will look like. The green is time in range, yellow is time above, below is time below, and there are two grades in both. So time above 180 to 250 is grade 1 hyperglycemia, above 250 is grade 2 hyperglycemia. If the patient has a DKA or honk, then it is grade 3. Similarly, 70 to 54, that's grade 1 hypoglycemia, below 54 is grade 2. If the patient is unconscious or having fits, fall, etc., needs other helps, then or requires hospitalization, that is grade 3 hypoglycemia. and these are the published guidelines. I will not really bother you about the whole details. Sufficient to actually keep in mind that given the patient's profile, so if it is pregnancy diabetes, then you require more, you can say, time in range. Rather than 70, you expect that it should be 85 or more. And the time in range is not 70 to 180 for a pregnant diabetic, but it is usually 63 to 140. You know very well that we require a stringent control for the pregnancy as well as the fetal outcomes. If it is an old man, then you are always going to avoid hypoglycemia as a priority. So time in range may not be, you can say, 70%. It could be something like 50%. And time below range is something which you should be careful. It should be actually reduced. It should be less as possible in old patients or those patients who have liver problems, maybe CKD, where you are more worried about hypo. CGM should be geared in such a way that hypos are avoided. There has been proofs that there is a significant, if there is a significant improvement in time in range, so that is related to microvascular benefits. If the time in range goes below 10%, then there is an increased risk by 64% of retinopathy, nephropathy by 40%. Similarly, if there is an improvement in time in range by 10%, there is a 6.4% lower risk of abnormal carotid intima media thickness, which is a surrogate marker of atherosclerosis, as you understand. We have our own position by our expert. This is the Indian consensus on CGM. We are aware that CGM needs some amount of money, some amount of motivation, availability, etc. So the Indian experts say that if the patient has, let's say, a very high hyperglycemia or very low, you can say, repeated hypoglycemias, then he is a patient who should be doing a CGM more number of times. If you do a CGM and the time in range is more than 70%, you can expect the patient to do it maybe after 6 months or 1 year, according to your discretion. But if the time in range is below 40, the patient generally should be doing more CGM, maybe every 3 months, again, depending on what you and the patient discuss out. So these are the recommendations of our own experts. Depending on the patient's affordability and depending on the clinical demand, you will be doing the CGM that particular frequently. And these are some of the examples to wrap up my presentation. These are, of course, problem patients which I have technically brought for your, you can say, view. This is an alcohol-related pancreatic disease. He has become insulin-dependent diabetes mellitus. I have used the old term with intention. He was a type 2, but his pancreas got actually dysfunctional because of alcohol. He has a very high HbA1c, and he is, of course, on multi-dose insulin regimen. He is a hotel owner, so he tends to actually have very irregular timings of his meals. So that's the way we travel, and you can very clearly see that his sugars are not exactly, you can say, very good. Time in range is 61. This is another example. He is hypertensive, diabetic kidney disease, again a high HbA1c. His eGFR is only 15. So we technically have to do with only insulin in these particular situations. And the time in range again here is 58. You can see that he tends to have some amount of hypoglycemias late night and maybe after his breakfast as well. Another patient who has liver cirrhosis, another example, type 2 diabetes but liver cirrhosis. He hardly tolerates any oral antidiabetic, goes in hypoglycemia. So we have to manage with him only short-acting analog insulins. He has no medication. When he came to me, 9.8 was the HbA1c. And he is somebody who is a Pakka Panduranga Bhakta. So during the Ashadi Ekadashi, he wanted to go for the pilgrimage. So he had put on the sensor. He was sending the readings to me. You can very, very clearly see that sugars are very high. All the time, the sugars are high. That bold blue line, the median, that actually hardly touches the time in range. But these are the situations where CGM can help him to abide by his own faith and devotions, and his diabetes can be managed maybe at least fairly. His time in range we could bring to at least 30%. Of course, we are continuing with the same right now also. Last example is 84-year male, 3 decades of diabetes, long-standing. He has already undergone an intervention in 2005. He is on maintenance hemodialysis over last 3 years, remains an HbA1c high, also meets with hypoglycemia. You can clearly see late night hypoglycemias. So CGM certainly helps him better manage diabetes. You can understand that maintenance hemodialysis keeps, you can say, changing the insulin resistance, fluid status, even the insulin, you can say, dialyzability. So from all that point of view, doing all these tight ropes, CGM is certainly going to help these patients have a better quality of life. We could attain a time in range of 74% in the this particular duration of 2 weeks. Before ending up, just to tell you what is happening now, this is Professor Tade Batelino, who is again a world authority in the field of diabetes technology, and he is already pushing for using CGM for those people who are not having a HbA1c of 6.5 or more, so they are not diabetic. But he says that those who have obesity or other metabolic risk factors which probably put them at a higher risk of future development of diabetes, then these are the ones where you do a CGM and not only look at 70 to 180, the traditional diabetes range, but look at something which is called as time in tight range, which is 80 to 140, and see whether they are ranging above that. It has been proved that those who tend to have more than 28% time above range, TATR, above 140 of the upper limit, they are more likely to have type 2 diabetes in near future. And this is the policy which has been again recommended by our own expert led by Professor Mohan, Professor Jyotidev Keshevdev, for optimizing continuous glucose monitoring adoption in India for us, the authorities, the decision makers and all those. Gentlemen, thank you so much for your kind attention. Thank you so much.